quiz 2, this is 30 items, the parking score is 23.
Quiz 2 was 25 items.
25.
Quiz 1 was 30.
No, quiz 2, this is 30.
No,
Quiz 3
Oh,
is
quiz.
Oh,
sorry.
30 and quiz 3 is 20.
Okay. There you go.
You're just
We thought you
thinking
meant
about
second.
that.
We got overly excited, sorry.
Sherry,
Thank you.
Dennis,
Wait, what can you can pass me
Amy?
23, right?
I think so.
Liam,
You do put oxygen.
oh, really?
What'd you get?
Wait, isn't it gluconate? What did you get?
Yeah.
23.
What did I write there?
Oh wait, no, never mind. Okay.
I got 23.
Why do you put anything in
If I crossed it,
Okay.
yeah.
Yeah, I know. I was
21
just
is,
sorry.
That was gluconate. I thought gluconate,
21
but I
was
put
the thing, right?
yeah,
How come it says wrong here?
it's like that. Either way.
Oh yeah. I had a question.
No, you had to
Oh,
put
no,
an
no, no.
E on 21.
Oh, is it the Celsius?
Yeah.
Oh, okay, that makes sense.
Why E? For 21
Why did
is how much, what's the temperature?
No, 21 is calcium gluconate.
Yeah.
Yeah, that's fine. That's fine here.
No, it's a fill in the
We're
blank.
talking about-
It's a fill in
No,
the
it's
blank.
just that you get, if your answer is correct,
Yeah.
it's okay, but you will not be given additional credit for writing
Oh, okay.
solution at the back. But if, I will ask Miss Joy, if there is no solution at the back,
It
with
says
the
on the
correct
page.
answer, she said no credit, so
Yeah.
that means -1. I will have to confirm. it.
No, that's fine. So basically they took it out here. They took it out here, but they put it back in. She put it back in here. You know what I mean?
Oh,
So it's fine.
I got it.
Are we gonna go over it after?
After.
Yeah.
Thank you.
Okay.
Yes.
What'd you get?
What'd you get?
28.
Of course. Crap. Why
28 out of
Why
25.
I know. I always do that to myself too. Fuck, why?
Just make us feel bad or something?
Yes, very much so.
that one's out of 25.
And this one is the 25.
But
And
that was
this
out of
That was the
30.
first one is out of 30.
Second was out of, this one I did too
So
good.
here the passing, I think, is 19. 19? or-
Yeah, 19. It's a 76 for 19.
Cindy?
What did you get, boy?
Oh,
Ben, thank you.
What is
20. What? Really?
Monday,
Yes, ma'am.
Dennis,
How many do you need to pass?
19.
19. Crap, I got 18.
Sherry, Darlene,
I got 15.
Leo,
16.
My heart is pumping.
Brittany,
Brittany.
and Amy.
What did it?
Oh, 19. I barely passed.
No,
I got
Do
18.
you got 14. I don't know what happened to this.
Hmm?
It got destroyed.
Oh, God in heaven, Denise.
I know.
Wait, I have a question. This is plus 1 too, right?
Oh, so that's plus
So plus 2, so it's 20.
11.
Okay.
I did more. Yeah, I went down to 7.
Can I double check the other one? Maybe my other one had the same thing. Sorry.
What was it? The 76 going to 77?
Damn it.
Yeah, this one too.
Okay.
Yeah, so right there. And then you added the one from the back. And then you need it. Yeah, one more there. Right? Okay, better.
You have your Scantron with
I'm
you?
good if I stayed at 8 and 9.
So no more Scantron, everybody return the Scantron?
Okay, let's go back.
So we were talking about the different methods of injecting or administering insulin. So we already talked about the insulin syringe. We talked about the insulin pen and the injector. The jet injector is not frequently used. For what reason? Even though there is no pain, because you don't require a needle to administer the medication, the problem is it is very expensive. That is why the advantage usually is outweighed by the disadvantage. So the insulin here is administered through a mist by the speed and the pressure used during administration. I think you have seen the picture in your book. And then we have the insulin pump. With insulin pump, many people are comfortable with this because this pump delivers basal insulin. So say basal continuous administration of insulin, and people feel comfortable because they could eat whatever they want to eat with continuous titration of insulin. And you have seen there the picture in your book with what composes an insulin pump. You have the pump itself, the tubing, and the needle. The needle is attached to the skin on the subcutaneous layer, so there is a special belt that holds the pump. And the needle is usually replaced every 3 days. We could not make the needle stay for more than 3 days because the problem is possible infection. Okay? The problem with this is, although we said there is advantage, the person could eat whatever they want, there's continuous supply of insulin, but the major disadvantage is when the pump fails, the patient will develop hyperglycemia. And another thing is with the pump, because continuous titration of insulin means that you could be risk for hypoglycemia, then the individual should be religious in doing the finger stick monitoring with the insulin pump. Okay? So that is a regular insulin that is widely used today. All right. So these are the advantages, and we have disadvantages. Few people are using the insulin pump actually, because with the insulin pump, it means that when you hear the sound, when you're studying, you could be distracted. And then some people would want to do water exercises. It's not easy to have a pump. You have to remove it. And then it makes some noise that would cause disturbance with using the pump. Okay, so I said with the failure of the battery or the pump, you could develop hyperglycemia. Now we have the oral hypoglycemics. There are 3 major types of oral hypoglycemics that are in use today, because the other one is still on clinical study. Why do insulin cannot be given orally? Although most people would want to get away from insulin, because insulin, when given orally, is destroyed by gastric enzymes. That is why they are not given orally. There was an insulin known as Ixubera, that is the inhaled insulin, that was discovered 2005. That was removed from the market because other than it is heavy, it costs also a lot, plus the major factor for its removal is it causes cardiac and lung complications. That is why it was removed from the market. Now I think they are discovering, or they are in the process of, I don't know when that will be released, they have the insulin patch. And they said this insulin patch makes the pores of the skin, once applied, makes the pores of the skin dilate. And then insulin is easily absorbed into the pores of the skin and is carried into the blood or systemic circulation. But it's not yet in the market. Okay? So we talk about oral hypoglycemics. I said there are only 3 that are commonly used today. We have the sulfonylureas. It's called sulfonylureas because this was conceived when they have discovered that sulfa causes decrease in the inflammation that is believed to cause diabetes. So they have created the sulfonylureas. Sulfonylureas are called insulin releasers. They help stimulate the pancreas to release more insulin. I think I mentioned this morning, that one of the adverse effect is insulin burnout. That is, the pancreas cannot anymore produce insulin because of long years of stimulation. So this includes the, the glipizide, the glyburide, the Amaryl or glucotrol. These medications need to be taken before a meal, okay? So that ready for intake of food is already insulin released from the pancreas, all right? Now, when the patient, by the way, is taking oral hypoglycemic, we usually tell them to avoid drinking alcohol, okay? Because alcohol can cause hypoglycemia, okay? And then the other group is the biguanides, all right? So we say biguanides. The first FDA-approved biguanide is what? Metformin. That is glucophage. Now, this medication is usually given with meals, all right? So you have different dosages of metformin. Now, unlike the sulfonylureas, which can cause increase in weight, metformin do not cause increase in weight, but it can cause abdominal cramping, it can cause diarrhea, and may predispose the individual to a little, risk for lactic acidosis, okay? The TCDs that you have there, Avendia, then you have the other one is Actos. All those still prescribed today. Most doctors do not really prescribe them to patients. For what reason? Because they have potential to cause cardiac and renal complications. That was the reason why they were removed from the market before. But now they're back, like Actos. They can cause edema or fluid retention, cardiac and renal problems, okay? So doctors give it if they think that the benefit the patient could get from that outweighs the disadvantage. But of course, there are many choices. So why insist on something that is associated with lots of with lots of side effects? And then we also have what is the other group? Precos and the carbos. These are
The alpha.
huh?
The
Alpha glucosidase.
Okay, alpha glucosidase inhibitors. Okay, so alpha glucosidase inhibitors, the mechanism by which it works is this medications usually slows down the metabolism of complex carbohydrates. So it helps prevent a sudden surge in the postprandial blood glucose. So when you eat during meals, the sudden rise or spike of blood glucose is prevented. This medication is also used for people with type 1 diabetes for the same reason. What is that reason? To prevent a sudden spike or surge in the blood glucose level. All right. Now the thing is, we said it inhibits the metabolism of complex carbohydrates to turn it into glucose. So therefore, when the patient develops hypoglycemia, you cannot give alpha glucosidase inhibitors. Why? Because it would inhibit the conversion of carbohydrate that you give into glucose. So if the patient develops hypoglycemia, therefore, what are we going to give? We have to give glucose already. You cannot give orange juice like the practice in the facility, because that's not going to work. So you have to give glucose. If you give glucose for a patient who is hypoglycemic, you have to make sure that you determine the client's level of consciousness. No oral glucose if the patient is not fully conscious. But you could give glucose into the oral mucosa, the gel, that just disintegrates or dissolve in the mouth. Otherwise, if the blood glucose is still high, you could call MD for the administration of glucagon, which could increase the blood glucose level. All right. Now, in case of hypoglycemia, or before we go to that, these are the different reasons for giving oral hypoglycemics. So one is that the patient has type 2 type 2 diabetes, plus the blood glucose level is fasting is less than 200, and the insulin requirement is also less than 40 units per day. And the other one, the patient does not have ketosis. Ketosis is only for what? Type 1 diabetes. That is why these oral hypoglycemics are frequently used for people with type 2 diabetes. All right. So if we're going to summarize, what are those three major types of oral hypoglycemics that we discussed? So insulin releasers. These are the what?
Second generation.
Sulfonylureas. All right. Then we have insulin sensitizers. Okay. What are these insensitizers?
Like one.
Sensitizers are what? Biguanides. Okay. And then we have
Alpha glucose.
oral medication that inhibits the conversion of complex carbohydrates to glucose. We have alpha.
Glucosidase.
Okay, glucosidase inhibitor. Okay. So what is alpha glucosidase? It is an enzyme, right? That converts complex carbohydrates into glucose. All right. So those are the three major oral hypoglycemics. The other one are still in, what is that? In the process of being, experimented. Okay? So with oral hypoglycemics, you should know what are those which are supposed to be given before a meal, what are those which are supposed to be given with meals, and what is that which should be given before meals. So the one that is given with meals are the biguanides, that is metformin. Before a meal, we have the sulfonylureas, and then we have the alpha glucosidase inhibitor. Okay?
They should all avoid alcohol, right?
Yes, all of them. When you're taking oral hypoglycemics, you have to avoid alcohol. Now, if you are pregnant, please consult with your doctor, because oral hypoglycemics could lower the blood glucose level, and glucose is needed by the fetus, for energy and for metabolic needs. Right? So those are the oral hypoglycemics. There are other medications which are, according to the book, are given as adjunct. When you say adjunct, additional only. So when you see the word adjunct, it means say that they could not be given alone, right? They are supposed to be given in combination with other oral hypoglycemic. Like for example, you have adjunct medications like Januvia. You have also injectable medications like what? Bayeta. But I said they are not supposed to be given alone. And then hepatic and renal functions need to be monitored while they are taking the medication. So therefore, what is a common complication of patients who are taking oral hypoglycemics? Other than hypoglycemia? GI upset, diarrhea, fluid electrolyte balance, and then also insulin, pancreatic. Okay? So other than insulin, other than the oral hypoglycemics, what else usually are, shall we say, other modalities of treatment in diabetes, just to recap?
Transplant.
Okay, pancreatic transplant. Who is a candidate for transplant? Type 1?
Type 1.
Or type 2?
Type 1.
Type 1. Why type 1? There is no insulin produced. What do they need to do the transplant? Transplant is using the pancreas, whole pancreas. Maybe coming from humans, or maybe coming from what? The pig. That is the common source of in, what is this? The pancreas. But what is the problem with pancreatic transplant? Like any other transplant, the patient would require medications that would prevent what? Rejection. So what are those examples of medication? The program, okay, what else? Tacrolimus, they're all there in your book. But usually they do not give corticosteroids. What is the reason?
Blood sugar.
Blood. It make you hyper.
Okay, corticosteroids increases the blood glucose level. That is why they are not given. Now what about the pancreatic islet transplant? Is that the whole pancreas too? No.
It's just that.
No, these interventions are rarely done. That is why you don't see them in the APLEX. All right, so anyway, with pancreatic islet transplant, this is done through endoscopic procedures. The beta islets coming from several sources, maybe two pancreas, will be injected directly into, where is it injected? What is the use of that book in front of you? Where are they injected?
Abdominal.
To where?
Portal vein.
Okay,
Abdominal.
abdominal wall to the portal vein and to the hepatic, what is the system, and then immediately, according to the study, once injected, they are going to produce what? Insulin. So the person will not require insulin, and the person can eat anything that they want. How long is the effectivity of pancreatic islet transplant?
2 years.
2 years. After that, no more. Then the person will go back again to what?
Insulin administration.
So, but at least you have 2 years
And you can enjoy whatever you want.
of no injection.
Can
Okay.
they continually do that one?
And then
Oh my
continually
goodness.
like
You know, the
There's
donors
something-
may not be that much because you don't only need one pancreas to harvest the beta islets, but you have to have 2 or more than that in order to harvest the pancreas. So these are, so which of the oral hypoglycemic cannot be addressed by giving, shall we say, orange juice? Alpha glucosidase inhibitor. Okay. Now, if you see the patient with diabetes who seems to be having problem with altered level of consciousness, what should be the thing that you will do? Assume that the patient is having hyper, or assume that the patient is having hypoglycemia? It's better to assume that the patient has what? Hypoglycemia. So what is the first thing that you do? In the NCLEX exam, you're asked that question. The first thing that you do is not to administer insulin or orange juice, but the first thing that you do is to get a finger stick in order to confirm whether the person is what? Is hypoglycemic or is hyperglycemic. All right. Now, your book also mentions the rule of 50 in the management of hypoglycemia. What is the rule of 50?
Give 15 grams.
Okay, give 15 grams of what?
Rapid absorb.
You have there a list in your book. There's a small box in your book that talks about what contains 15 grams of carbohydrates. So you have their Lifesaver, 6 to 8 pieces. Then what else do you have? A soda. What else? What else do you have? Orange juice.
Fruit juice, soft
Okay,
drink,
fruit
honey,
juice, soda. Okay.
syrup.
Honey, all right. You
What
can
was
give
the
that.
sugar?
Those contains 15 grams of glucose.
Glucose.
And then after that, observe for 15 minutes. And then
Recheck blood
check
sugar.
again the blood sugar. If it is still below 70,
Administer
Then administer another
15 grams.
another 15. But still it doesn't go up, what will you do? If it is at home, call 911, right? If it is in the facility, inform MD. What do you think will be the last remedy? It's not responding to anything oral like you're giving. In the rule of 50, it is glucagon or administration of glucose. Okay? Dextrose, 50%. The 50% glucose is usually administered IV. What about glucagon? Oral? No. Glucagon is administered parenterally. Okay? It's going to raise the blood glucose level high.
Wait,
Okay?
you said 50% dextrose?
Yeah. D50. It's called D50-50
D50-50.
because the 50% glucose or dextrose is in a 50 ml solution. So therefore, for every ml, you have
There's
what?
one.
1%
Yeah,
of
dextrose.
glucose solution. Okay? So, like what I said, the donor for the transplant is what? A pig. Or a human being. Okay? So you need more in order to make sure that the pancreas is enough. So these are the immunosuppressants, except what? Corticosteroids.
Steroids.
Okay.
So they have two pancreas then? When they
What?
do the transplant? Or at the,
For the pancreas transplant, one. But to get a pool of beta islets to
Oh,
be
they have to
injected,
have
you
that.
need more than one. But usually they don't do this. Okay? So we have to check for signs and symptoms of rejection. So what would be your, what is this? Your nursing management. But before we go to that nursing management, let's first talk about other complications. What are other complications? This comes from an old edition of the book. It's not updated, that is why it's long presentation. What are other complications? We have what?
neuropathy?
All right, neuropathy. And then what is the other one? Nephropathy. Okay. Then we also have
Retinopathy.
retinopathy. All right. So when we say neuropathy, what are the neuropathies? The neuropathies that we have motor, isn't it? We have sensory, and we have ANS, neuropathy, autonomic nervous system neuropathy. So when we say motor neuropathy, what primarily characterizes motor neuropathy?
Muscles weaken and atrophy.
Okay, muscle weakness. So we have here a possibility when you make a nursing diagnosis. A client may be risk for what? May be risk for
Risk for injuries.
it's risk for injury. So the foot, they said, usually becomes wide, and the gait is affected. So therefore, the patient is risk for fall. And then sensory, you have the many forms of what? Paresthesias. Okay. So again, the person is risk for injury
Yeah.
because you could not feel the right temperature. You don't know that you're holding something that is sharp. You are risk for injury. And then ANS, autonomic nervous system, sympa, and what? Parasympathetic. A very common ANS is gastroparesis. All right. What is gastroparesis?
It's when your stomach.
Gastroparesis is delayed GIT motility resulting to delayed gastric emptying. All right. So what usually will the patient complain about?
Constipation.
Patient complains not only of constipation but fullness. Patient feels like the food is not going as expected. So the management for this is administration of a medication. You have this in GI, which is going to help with the emptying of the stomach. That is what? Regular. What are the three major macronutrients is difficult to empty on time? Fats. So we tell the patient to avoid eating a lot of fatty foods. Okay. Other other ANS problem includes erectile dysfunction. Okay, or decrease in libido. So for erectile dysfunction, what would be your nursing? What is your stand for patients who are complaining that their sexual life is suffering? What could you tell them? You have to refer them to what?
To the doctor.
For sexual
Yeah.
counseling. You cannot just tell them, take Levitra, take Cialis, take, what else? The other one? There's so many now.
Viagra.
Viagra like that, because these medications could have an effect on the heart, cardiac problem. Okay? So refer them for counseling. Because many patients have diabetes because of nerve involvement suffers from a diagnosis of impotence. Okay? right. And then what about nephropathy? What is the best? Nephropathy is common in patients with type 1 diabetes, but may also occur in patients with type 2 diabetes. So what medication usually is expected to be ordered by the doctor? The doctor will order for a medication that is primarily going to control what? Hypertension. Hypertension is one of the many causes of renal problem. So what are those medications? ACE inhibitors,
Beta blockers.
okay, and angiotensin 2
Oh. Yeah.
inhibitors, okay. Okay, what is the example given in your book here? ACE inhibitor?
Anything with pearls.
Okay, captopril or capoten. What about here?
This one.
Hmm?
Is it certain?
Cozar, okay, is an example of angiotensin 2 inhibitor. Okay, so improve renal blood flow in order to prevent nephropathy. Usually renal problem would develop for a maximum of over the time. If the patient develop renal failure, it is called chronic renal failure. Okay, and from the time of onset, usually the total, it takes about 20 some or 25 years for total kidney failure to develop. So if the total kidney failure will develop, end-stage renal disease, this patient will go for a dialysis or a kidney transplant. That is the management. Okay? Any question here? Why you look sleepy? It's because of the room? My voice is loud enough.
Too much food.
Too much what?
Too much food.
Too much food. Okay, so don't eat a lot. Okay? So we are concerned about this, right? So we monitor blood pressure and we make sure patient complies with medication. Retinopathy. What are the two types of retinopathy? Retinopathy. We have the
Non-proliferative and
Okay. Now this is the milder one. And the other one is?
proliferative.
Okay, proliferative. So proliferative is the most serious one. It can even cause microaneurysm. So it's a microaneurysm, saccular growth in the blood vessel in the eye that could rupture and cause what? Hemorrhage, right? And blindness, okay? The patient with diabetes is risk to developing what type of eye problem? Retinal detachment. Okay. Now, huh? What is it, Dennis?
I'm just like picturing how would that
How would what?
Attachment.
retinal detachment, like
Oh, when you say retinal detachment, the retina is considered the eye apparatus, correct? There are two parts of the retina.
So they
You
go
have the
blind.
pigmented layer and you have the sensory layer. So when it splits like that, the sensory is separated from the pigmented layer. So the retina is not going to receive what? Images. So you have problem with vision. Okay? Now usually the retinal detachment is a result of rupture of these capillaries. When the capillaries rupture, they could sit into the posterior chamber of the eye where the retina is located and mix with the gel-like structure in the eye. What is the gel-like structure in the eye that gives shape to the eyeball, which is located in the posterior chamber of the eye? We talk about the vitreous humor. All right. That is why part of the management is if there's too much spillage of blood into the vitreous, they remove the vitreous humor. What is that surgical procedure? Removal of the vitreous humor? It's just right there in your book. You're already sleepy, so I don't want to give you page by page, paragraph by paragraph, so that you are going to wake up. It starts with B also. Vitrectomy. All right. And to maintain the integrity of the vessel to prevent further proliferation of abnormal blood vessel, the patient is given another antihypertensive medication, lisinopril. Okay, that is part of those medication given to the patient with retinopathy. So with retinopathy, what will be a nursing diagnosis? Potential for what? Altered vision. So what would be the problem of an individual with altered vision?
They can get hurt.
Risk for fall, risk for trauma. So what would be the recommendation? You think of a doctor to a patient with with retinopathy. Yearly what? Yearly
Eye exams.
eye checkup. Okay? And then, what else? Okay, they can use assistive devices if they have problem with vision. Usually they can use a cane if they're totally blind, right? So just make sure that everything at home, there are no clutters in which the patient could stumble and could fall. All right. Now, the nursing management for patients with diabetes includes a lot of things. It is multi-dimensional, and I said patients with diabetes plus the family should be included in the plan of care. So what are those nursing management other than the medication? We talk about what? Compliance with diet. What else? Exercise. Drinking enough what?
Water.
And then talking about what is this? Atherosclerosis and arteriosclerosis with decreased arterial flow. We tell the patient to avoid as much as possible occasions that can cause trauma. Are they supposed to walk barefoot?
No.
No. All right. What about foot care? When they clip their nails, how should? All right.
Straight, yeah.
Across. All right. Are they supposed to go to foot spa for a pedicure? No.
Should go to
They have to go to a podiatrist. Okay. Before they put on their shoes, they have to inspect the toes, the foot, because sometimes they already have ulcer. They don't feel that they have already ulcer. I think you have seen patients in the clinical area that you just discover that there is a blockage, discoloration. What is block? What stage is that?
It's dead. It's a
Four,
stage 4.
right? So is it possible for a stage 4 to happen overnight? No, maybe there is no assessment. So foot assessment for possible ulcers which are not healing. Inspect in between the toes, make sure they're what? They are dry before the patient puts on what?
Their socks or
The
shoes.
socks. Now, to address circulation, other than this antihypertensive medication, what non-pharmacologic measures are usually recommended for patients with diabetes
The diet.
to prevent to prevent ulcer formation and to enhance blood flow? They are also talked about using what is the stockings?
Head stockings.
Okay, bed hose, maybe knee-high or thigh-high stockings in order to improve blood flow. Now with altered blood flow, decreased blood flow, problem we said is neuropathy, so nerve involvement, and paresthesias in patients with diabetes mellitus may be associated with pain. So painful paresthesias is experienced by people with nerve pain. So the doctor may give medication for nerve pain. As much as possible, they do not give acetaminophen because acetaminophen can cause kidney problem. So what usually are given? Antidepressants like what? Tofranil. What else? Anticonvulsants like what? Gabapentin. What is gabapentin? Gabapentin is Neurontin, correct? And the other one is Tegretol or carbamazepine. And now, FDA approved medication to manage nerve pain in patients with diabetes is Lyrica.
Oh yeah, Lyrica.
I think you have seen that
Yeah,
on
commercials.
television. However, this can cause severe drowsiness. It can even cause suicidal ideation. So you always talk to the patient what to report when they are taking the medication. And they have to be wearing comfortable shoes. I think we have now areas that provides diabetic supplies. Okay? I think we have one here along Sepulveda. Even the shoes should be properly fitting. We also have diabetic shoes. And then please tell the patient not to work. If they want flowers, they're not supposed to grow roses. Why? Why not roses?
The thorns.
Yes. So of all flowers, get away from what?
Would it hurt you?
Okay. There are some people who love roses. Of course, everybody loves roses. But it's not easy to take care of what? Roses. Now, if you suspect, for example, that's a question. If you suspect altered blood flow in the peripheral parts of the body, how would you document altered blood flow? Document
Tissue
altered blood
perfusion.
flow and monitor by checking temperature. What else? Pulsation. Decreased pulsation would mean altered blood flow. All right. So these are long-term complications. What about short-term or acute complication? We have DKA and we have HH and KS. All right. What is this DKA?
It's the increase in lactic.
Usually seen in people with type 1 diabetes. So what happened is there is too much food, stress, illness, decreased insulin. So the net result is what? DKA, right? And what happened in DKA, we said, breakdown of fat in gluconeogenesis would give rise finally to development of what? Ketones. You know the sequence from the beginning, huh? Fatty acid, lactic acid, keto acids, and then ketones in the urine. Characteristic of increased ketones in the urine? Osmosis respiration. And then acetone breath, correct? And what happened here? The patient will demonstrate the 3 P's. What are those? There is actually no polyphagia. We have just major manifestation is what? Polyuria. Right. So here, with polyuria, the serum osmolarity increases. So the result is the level of sodium and potassium increases. Take a look at your book so that you could correct me if I am wrong. Is that right?
Yes. It's
Electrolyte
elevated.
imbalance plus polyuria would give rise to dehydration. Okay. So the patient usually is flushed. The skin is dry. So for hyperglycemia, the key word is flushed and dry.
Skin.
The sugar is high. All right. That is with hyperglycemia. Okay? But with hypoglycemia, cool and clammy needs a candy for patients who have hypoglycemia.
What is it? Colon.
Clammy needs a candy. Of course, you have the glucose, right? Okay.
What is this one again? I'm sorry, I can't read that.
Flush and dry. The sugar is high. Okay? So, here the blood glucose level is what? Up. How much? More than 300, right? So what is the management? We have hyperglycemia here. We have ketones. What is the management? To lower the blood glucose, to slow down the production of ketones. All right. If ABG is the question, what would be your answer? The patient will develop what? Metabolic acidosis. Correct. So I thought you are not listening. You are also listening. So dehydration. So what is the management? First is what? Insulin, correct?
Yeah.
Insulin IV. That is what insulin? regular insulin. And then, IV fluids. Usually they give insulin with IV fluid. Imagine to order 250 to 500 ml per hour. IV with what? Insulin to bring the blood glucose level down.
5 units per hour.
What would be your problem here? Rapid infusion of IV fluids to address dehydration and hyperglycemia. What would be a problem?
Hypoglycemia.
This is IV fluid. Administration of rapid administration of intravenous infusion
Fluid overload.
would lead the nurse to monitor for which of the following. So what is the stem in the question?
Rapid.
Rapid administration of infusion. So what is this asking about? What should you monitor?
Fluid overload.
Yes. Signs of fluid overload
Yeah,
or
right.
circulatory overloading. Okay? So what could be signs of circulatory overloading?
Crackles in the lungs.
Dyspnea, crackles in the lungs. Edema will develop later. Okay? Alright, so, and here we have the electrolyte imbalance. What particular organ in the body needs to be monitored too? Okay. Patients may be attached to a cardiac monitor. What ECG tracing would suggest? Hyperkalemia. Elevated U waves, okay, or peak T waves is suggestive of what? Hyperkalemia. The patient may develop cardiac dysrhythmia. All right. By the way, just to review cardio, what is the medication given for hyperkalemia? To inhibit further absorption or distribution of calcium in the system, in potassium? There are two. One is what? Kayexalate. You cannot give diuretics here because the patient is dehydrated. You cannot give diuretics.
So they can give Kayexalate?
Kayexalate is for what?
And it's
Hyperkalemia. Kayexalate only and potassium exchange resin, that is D5 water plus insulin. Remember cardio? That is for
I thought that's calcium for some
hyperkalemia.
reason.
All right. So we're good with that. At least we remembered some. Okay. So-
Only
And then monitor intake and
out.
output. Okay. Any question, Amanda?
No.
Great, so IF.
So, are we okay with DKA? So signs and symptoms?
Yeah.
Polyuria,
Yep.
flushed skin, dry skin, frothy, odor in the mouth or acetone breath. Then signs and symptoms of what? Dehydration. Okay. So management includes what type of insulin administered IV? Regular insulin. Intravenous infusion. Attachment to cardiac monitor. Monitoring for acid-base imbalance. And monitoring for serum sodium and potassium level. Then monitor for signs of circulatory overload with rapid intravenous infusion. Okay? What about HHNKS? Usually seen in people with type 2 diabetes. All right. Is this the same? Is there hyperkalemia and hypernatremia in patients with HHNKS? I always tell you to look at the book so that we're on the same page.
Sodium
Yes.
is low.
Okay, so in HHNKS, the patient may have same manifestation, polyuria, sign of what? Dehydration. However, remember,
It's hypocalcemia.
there is decreased sodium and decreased potassium. All right. So if the potassium is decreased, the potassium is increased, do we have a different management? Is the heart still affected? Yes,
Yes.
because sodium, potassium, and calcium are three important cardiac electrolytes. So what is the management for this? The management is the same with what? Diabetic ketoacidosis.
Really?
Yeah, but the patient usually will have problems with a different what? Electrolyte level. So if you want to double check, take a look at your book, and then you have to read the difference between hyper and hypoglycemia. Hypoglycemia is not difficult to remember. Why? That is how you feel when you are hungry. How do you feel when you're hungry?
I shake.
You cannot understand what is being discussed. You feel shaky. You will become diaphoretic. You will be hungry. What is in your mind is I have to eat, like that. All right. What about in hyperglycemia? Do you feel like eating? No. There is even nausea and vomiting. All right. And then in hypoglycemia, the patient, if not managed, is going to go into coma because there is decreased glucose to the brain. What is the #1 source of energy for the brain?
Sugar, glucose.
It's a major source of energy. How do you address hypoglycemia? What is the first thing that you do? That is usually the inflex question. The nurse thinks that the client is hypoglycemic. What should be the initial action of the nurse? And then, after checking the blood glucose level, what is the next thing that you're going to check? Find out whether the patient is conscious or unconscious. So you will know what is the route of administration of
Medication.
glucose, whether IV or oral. Okay. So any question? How is diabetes? Very easy, right? You will see. You will have 100 items.
Really?
Yeah, that's okay.
Hard.
Yeah, it looks like 100 items. All right. So anyway, what is the major thing about diabetes that you have learned?
There's
There are only two
There's two
types.
types, yeah.
Okay. The others are not really.
Yeah, what do they call it? Diabetes insipidus.
Huh? Oh, diabetes insipidus is a neurologic problem or in which there is a problem with anti-diuretic hormones. The patient do not have anti-diuretic
So it has nothing to do
hormones.
with this at all.
No, they are not even relative. Nervous system disorders, insipidus,
Why
and
did
this
they-
is an independent problem.
Why did they put it here then?
What is insipidus? Is that there?
No, it's in the chapter 15.
Well, that is with the nervous system.
No,
No, it is endocrine.
Yeah.
That is the opposite of syndrome of inappropriate anti-diuretic hormone. But the problem is the posterior pituitary do not release ADH. Or there could be the ADH, but the kidneys are not responsive to the ADH. You have central and you have what? Nephrogenic type of diabetes. Okay. Also, you have that also in Indo. Yeah, I think so. So what is the test for insipidus? It's not FBS, right? What is the test for insipidus? To confirm central or nephrogenic type.
Yeah, you
So
give
did
them
you
the
have
medication
injection?
and then if it's not,
That is the fluid deprivation test. After the test,
And
the
then it's
patient
the
is given
ABP.
desmopressin, correct? All right. So there are only two types, and the management includes exercise, diet. So you start with those first. Exercise, diet, then medications.
Yeah,
What are those medications? Insulin. You have different types. Short acting, rapid acting, intermediate acting, long acting. Then three properties, do not forget that. The onset, the peak, and the duration. Then the sites of administration, I have to mix insulin. Then we have oral, hypoglycemic agents, the rule of 15, okay, and what to do when you think the patient is having problem with either hypo or hyperglycemia. Okay?
Oh, wow.
So usually when I do the lecture, it's all arrows. But can you understand the arrows on the board?
Yeah.
You like arrows?
Yes.
Good. All right. So we are going to, if you have no questions, we're going to
Quiz.
review your exam. I don't have a transparency for this. So maybe, you know what, they don't want you to have the test paper.